Respiratory distress syndrome is the most common cause of respiratory distress in the preterm babies. It's primarily due to surfactant deficiency, and the incidence is inversely proportional to the gestation of the baby. So this is a simple slide showing you the different stages of lung development. So we have the embryonic stage in the first 8 weeks when the lung budding happens, the pseudoglandular stage when mainly the division of the airways in the upper bronchi and the lower airways happens. So we have the bronchioles and the terminal bronchioles up to 16 weeks. The canalicular stage, smaller respiratory bronchioles start forming, and it's a stage from 16 to 24 weeks. Surfactant production starts at this stage, though it doesn't get released. The saccular stage is the main stage when you get alveolar ducts and then the alveoli developing, and the surfactant starts getting released from the stage onwards. However, if a premature baby delivers earlier, the surfactant release may start. The lamellar bodies are stored at this stage and then they get released earlier. And so the final alveolar sac formation happens only after 36 weeks. So you should remember that a premature baby born in the canalicular stage, late canalicular stage, like we have the 22 to 24 week babies, hardly have any alveoli. And actually the modern BPD happens due to an arrest of lung development at this stage. So the lung does grow, but it may stop with the saccular stage. It may not go to the alveolar stage. So the reserve in these babies as they grow older will be reduced as well. And similarly, the vascular formation also is going to be compromised. And that's one of the main reasons that we get persistent pulmonary hypertension with BPD in these babies. So this illustrates from different sources the incidence of respiratory distress syndrome according to the gestational age. So obviously, almost all babies at less than 26 weeks have RDS, and at 28 weeks, you have about 60% chance, and 32 weeks, you have about 20-25% chance. It keeps dropping after that. Even a term baby may have RDS, especially if the mother is diabetic, but the incidence is much lower. Surfactant is a chemical which is a combination of protein and lipids. It's secreted by the type 2 alveolar pneumocytes. As we discussed, by 24 to 26 weeks of gestation is when it starts getting into the amniotic fluid. There is progressively greater in secretion with increasing gestation. It can be compromised in situations like diabetes, where the production of the surfactant is of slightly different quality, and the rate of production is not according to the gestation, it's delayed. It's composed of phospholipids like lecithin and sphingomyelin, which have surface active properties, and they also are compounded with surfactant apoproteins from A to D. Each apoprotein has a different function, but apoprotein B is very important for the surfactant function of spreading on the alveolar surface. And very important to note that most surfactant is recycled after the secretion. More than 80% of the surfactant that is released gets recycled, so the production is not as high. It's very important to remember this point when it comes to conditions like meconium aspiration syndrome or pulmonary hemorrhage, where the protein in the blood or the meconium denatures the surfactant that's present, so this recycling becomes very ineffective. So it can also happen with sepsis with the proteinaceous exudate in the alveoli. In any of these situations, if the ventilation becomes difficult, you may consider giving surfactant. The mechanism of action is obviously by lowering the surface tension. So as the name surfactant suggests, it has a surface tension lowering property, and it works at the air-liquid interface, and it prevents alveolar collapse. So it's very important to replace surfactant where there is a deficiency, and where you have problems in opening up the lungs, you may use surfactant in any underlying condition. So the inadequate surfactant leads to alveolar collapse and low volume lungs. The ventilation perfusion mismatch leads to worsening blood gases. When the hypoxia persists and you're not able to oxygenate well, and when the carbon dioxide rises, there is hypotension, further worsening of the acidosis because the tissues may go into anaerobic metabolism, and the hypotension worsens again with the increasing lactate and the acidosis suppressing myocardial function. And because of this hemodynamic changes, we may have an increased risk of intraventricular hemorrhage, because these premature babies who are at risk of RDS also have a very poor cerebral autoregulation. Because of this damage to the alveolar epithelium, we may have exudate coming into the alveoli, which leads to the classic hyaline membrane that we see as the important component of this disease. If it is untreated, progressive worsening happens till there is spontaneous surfactant production, and it either improves or leads to death by 24 to 48 hours.